Hello, everyone. Thanks for coming. I'm happy to introduce Sarah Fineberg, who comes to us from Yale School of Medicine, where she's basically spent her whole professional career after training. She went to Oberlin College. Some of us know people from Oberlin that we like. And then did an MD Ph.D. at University of Iowa, I guess Carver School of Medicine. Sarah's interests overlap mine in the sense that we have been interested in translation broadly, and in particular borderline personality disorder more specifically. And I was part of your K23 back in the day, and I'll just a couple of props for her on that before I say something about what she'll talk to us about today, which is, I don't know how many times you submitted that, but it was on the order of it would fill out my left hand or something like that. I mean, she is a gritty, don't go away kind of investigator. And in particular is very interested in taking basic science, facts and knowledge and translating it across clinical boundaries. And so my own group's interaction, that we've been interacting and publishing papers with her for 7 years or something like that. People like me and my group need clinicians that are interested in science on the other side of the clinical divides. There are all kinds of subtleties that you just can't get unless you've had clinical training and clinical experience. And I've profited from the interaction. Anyway, today she was going to talk to us about social learning and borderline personality disorder. And as soon as I turned around, the title had changed. It's now assessing borderline personality disorder as a disorder of social cognition. But take it away, Sarah, and thanks for coming. I appreciate it.
Let's see, is the microphone on? Yeah. Thank you so much, Reed. And I think I'll say Reed stuck with me as I did those many, many resubmissions of that case. So I'm grateful to him. As I was making a transition from molecular biology to clinical work, it was a little rocky. And I think many of us know this story of perseverance. So for any students who want to talk about persevering, I'm here. I am at Yale, and I currently do clinical practice in a public psychiatry setting. So I see patients who come in because they need care, and sometimes because no one else will see them. We take care of patients who get kicked out of other clinics because of their behavior or their adherence or lack of money. And so it's a really diverse and severe patient population, and many of them run into problems that exacerbate the underlying psychosis, mood disorder, substance use disorder because of their personality traits. So this has been an ongoing interest for me. And I'm going to try to talk about what I understand borderline personality disorder to be and some of the ways we've been thinking about assessment, some of the barriers to success in that realm. Right, I'm at the Connecticut Mental Health Center, which is a public psychiatry hospital, and I've had funding from a range of sources, including public and private sources. I do some consulting for pay for several pharmaceutical companies, and I volunteer on the board of the Borderline Personality Disorder Focused Nonprofit Emotions Matter, and also for the North American Society and also the International Society for the Study of Personality Disorders. So today I thought I'd start by telling us, making sure we're all sort of on the same page about what we're talking about when we're talking about BPD, and thinking a little bit about what it might feel like to live as a person who has this disorder. And then I'd like to talk about some of the things that I think are getting in the way of us doing work that really fully translates. So that's my plan. And let's start with ourselves. You know, everybody has a personality. And as you think about the people who you know, and maybe the people sitting next to you in this room, you probably know things about their personalities and the ways that they vary on traits. And this is one example that probably many of you are familiar with about how to organize traits. This is the 5-factor model. And one of the things that's important to think about is that it's not good necessarily to be high or low on any of these traits. The difficulty, and it's interesting actually, to have people around you who differ from you, and even to be able to be flexible in your own embodiment of these traits. However, we can get into trouble with very high or very low versions of each of these features. And you can see how, for example, many people in this room are probably quite high on conscientiousness. You have to be to proceed in this profession. However, if you go to the extremes of conscientiousness, you can insist on a degree of adherence to standards that can prevent you from ever publishing or ever putting work out or being able to finish, right? Or, being agreeable is really great. And here, since I've been here the last couple of days, I've seen that people are quite collegial here, and there's a lot of interaction among faculty and between students. And yet, if you're so agreeable that you can't protect yourself, you can see how you can range into problems. And so there are many stories like this. When we talk about borderline personality disorder, I find that the best way I can organize my thinking about what this is like, and the best way I can organize my thinking from an empathic stance, is to use the old psychoanalytic model. And here's how it works. The term neurotic here means people who can generally be counted on to get the tasks of life done. They can generally be counted on to do their job, to feel like the same self from day to day, to make and keep relationships that are nuanced in the sense that they can really imagine that someone else's mind differs from their own. And they're resilient under stress pretty much. This doesn't mean you don't have a bad day. This doesn't mean that you don't sometimes feel quite upset and actually have some trouble getting by. But usually you can kind of count on yourself to be the same you. By contrast, people in the psychotic spectrum, by this parlance, have trouble with all of those things. Most of the time, usually. Okay, so it turns out that there are people who live right on the edge, who much of the time are able to function at a pretty good level. There may even be people like this around all of us. About 1 to 5 in 100 people are experiencing this all the time, that they're kind of doing well enough that they come to expect themselves and other people come to expect them to get by at doing these important tasks of life. And yet, without too much provocation, these people find themselves really incapacitated at the fundamental task of being able to work, being able to get along, being able to feel like the same self from moment to moment. And this is why we use the term borderline personality disorder, people who are on this edge. And you can see how this could lead to intense shame, because it's very confusing at times to be able to do very well at these things and then to fall below the borderline and not be able to do them in a way that's really quite fundamental and profound. And you can see how this could lead to stigma, because if we have colleagues who we're counting on who seemed fine for a year, and then all of a sudden they're claiming they can't show up for stuff, you might feel like someone's not really trying, or that they're being lazy, or pejorative ways of thinking about this kind of fall into dysfunction. So I found this really useful in thinking about this and in talking to my patients about it. So borderline personality disorder, as I've suggested, is attended by consistent disturbances with a stably unstable baseline in mood, in perceptions, and in identity. And this leads to dysfunctional interpersonal relationships and often maladaptive attempts to regulate how overwhelming this feels. And yes. Yes.
Maybe get to this, at the risk of sounding pedantic with the classic nature-nurture question, which I don't mean to.
Oh.
It almost sounds to me already like BPD is something that emerges in some level in adulthood, but sort of task you're dealing with. But can a good clinician pick out these things in a young person that doesn't yet have a lot of responsibilities to go to work and school?
Yes, thank you for asking. This is so important. So, for a long time, we thought that borderline personality disorder could only be diagnosed in adults. I'm going to say this in a moment, but yes, we think this is a gene by environment interaction. So I think of it as sort of a two-hit hypothesis. People who are very sensitive in their innate structure and then encounter an environment that exacerbates the difficulty and then end up enacting as more life responsibilities take over. But generally, this is 12 or 13 years old. Many people who go on to have borderline personality disorder diagnoses in adults could have been diagnosed earlier, and that would have led to more helpful intervention and prevented loss of milestones. Because obviously that transitional age youth period of 15 to 25 or so is a critical period for doing many of the things that got us all where we are today, right? Like the way you perform in high school, the friends you make in high school and college, those are critical moments. And if you miss the opportunity to succeed at those activities because something chaotic is emerging and worsening, and the help you're getting isn't helpful, it can really snowball. So yeah, that's really, really important. And not only can you miss milestones, but also it turns out that there's a very high risk associated with BPD, that people have 50-fold more suicide attempts than the general population, and many go on to complete suicide. So some people in this room know this. I like to pause a moment on really how severe this feels. So Mary Lisa Johnson is an academic in the Southeast working in a humanities discipline, and she's written a beautiful memoir called Girl in Need of a Tourniquet. And she says, having borderline personality disorder is like bleeding out. And I think this evokes both the confusions about self-other boundaries, but also bleeding out is a life-threatening situation. And we should take that quite seriously when we think about how confusing and serious this condition is. These are the diagnostic criteria for borderline personality disorder, and they start with interpersonal instability, the perceptual disturbances in reality, in social trust, in self-image, affective and emotional dysregulation, and these risky behaviors that are often in a misplaced attempt to manage affect and feel better. I want to pause on how critical the interpersonal part is. Many researchers in this area and clinicians think of this as like a master switch, that when interpersonal problems are worse, the rest of the symptoms fluctuate in intensity. And we can think of the interpersonal problems as driving both increased frequency and amplitude of the oscillations of the other symptoms. Yes, please.
Is it kind of reinforced that because of those other aspects of their personality that they reinforce that, for example, the fear of abandonment, or do you think that these are independent of each other? Like, to what extent
Do failed interpersonal interactions over time snowball? Is that your question? I think so. Yes. Yes, I think so. Yes, I think that's how I think about it. You're probably hearing that in my presentation. There are certainly other theoretical models for BPD. You know, the most widespread theoretical model for BPD arises from Marshall Linehan's dialectical behavior therapy strategy, and that model centers emotion dysregulation. I would center interpersonal problems. I think the data about effective psychotherapy suggests that you can intervene at different points in the cycle successfully. So, you know, should you intervene on emotional dysregulation, probably you have a follow effect of more successful interpersonal relationships. If you intervene on theory of mind and people come to understand how to think about themselves, think about other people, respond better, the emotion regulation follows. So I would make a claim that probably more therapy religious people wouldn't, which is that probably most therapies are quite effective if you're doing something that's BPD focused. Now, what doesn't work is treating this as though you're treating treatment-resistant depression, right? And so you do need, I think, specific focus on the condition of interest. I hope that starts to answer your question. And I would claim here that we should be really thinking about this, because borderline personality disorder is highly prevalent even in the community. In community samples, there is not a gender difference. If we do large epidemiologic studies, so some of you know the NESARC data set, that's where these data come from. And marginalized populations are and minoritized populations are more likely to endorse symptoms, maybe because of the lifelong effects of experiencing minoritization. In clinical settings, and especially in psychiatric clinical settings, the prevalence of BPD is much higher, and the gender difference emerges. Women and female-identified people are much more likely to be diagnosed with BPD, although prevalence is high in the community, probably because of the way we respond to agitated men, which is more likely to be with legal consequences than with psychiatric care. So, right, we've sort of said this. We think that early and innate emotional vulnerabilities combine with environments that are perceived as invalidating to lead to chronic emotion dysregulation. And here I think it's important to pause for a moment on what we mean by invalidating environment and traumatizing environment, because there are certainly families in which one child has an innate sensitivity that leads to them to experience an environment as invalidating, where another child would do just fine and does do just fine, and that can be quite confusing for families. It's certainly the case that highly resilient people can get BPD based on extreme trauma circumstances, but that's not always the story of what's happened. The good news is that at least small studies, and these are data from 300 people followed for 25 years at McLean Hospital, suggest that remission here in the blue line and recovery, which is a more strict definition involving also psychosocial recovery, are common and increasingly common over time. I've marked in yellow the gap between remission, which is falling below the symptom threshold of 5 of 9 criteria for a diagnosis, and recovery, getting back to a life that most of us would accept for ourselves, where you have a job or school and people around you who care about you and who you care about. We should also be concerned that newer data from this lab that were published last year suggests that a lot of people lose remission once they get it. So it's not the case that once you achieve remission that you've got it and that you can hold on to it and that you've been cured. And so there's still a lot to do here. And one point I like to think about is, why is there such a big gap between remission and recovery? Like, you know, if you're no longer meeting criteria for the disorder, why are you still having so much trouble getting along in life? And I think part of it is the symptom definition. So you can not meet criteria for borderline personality disorder anymore and have 2, 3, 4 of these symptoms. And so what I tend to think is, if you look at these symptoms and you pick 2, and then you try to imagine living with those 2 every day, even if the other ones have gone away, things are still pretty difficult. So you can sort of start to see why maybe the definitions aren't helping us understand things quite as well as they could. Medications are not very useful, and the evidence strongly supports the lack of pervasive utility across groups for medications to treat BPD, and the FDA agrees and our national guidelines agree. However, doctors prescribe like wild. People are prescribing 3, 4, 5 medications, partly to come back to the point we were talking about a minute ago. You know, the concern is that if a patient who's highly distressed and who you even believe is highly distressed, or who maybe is highly distressing you, comes into your office and what you've got is a prescription pad, you use it, right? You try to be helpful in the way you can. And so people end up with polypharmacy. We might think that this is because of the common comorbidities, PTSD, depression in borderline personality disorder, but even in samples without those comorbidities, polypharmacy is common. This is probably unhelpful to patients, and there are data to suggest that the number of meds, that worsening of symptoms correlates with the number of medications that you're prescribed. There are psychotherapies that are helpful, but they are onerous. They are few and far between in terms of access. Dropout rates are high. Some of them are a full-time job for the patient. And response rates, even when people attend them, are not high enough. So we need to do better. People with BPD are continuing to suffer from mood symptoms and impulsivity that respond poorly, and social problems that amplify over time. And so when I'm thinking about this, I think that interpersonal problems are the core of this disorder, and this is where our focus should lie. And I'm concerned about a few things that I'd like to talk about here today. One is that our tools for measuring BPD and thinking about change over time really have not been validated beyond the self-report scales. When we use tasks, we don't think about the validation of tasks in quite the same way that we might think about scales. I'm concerned that we haven't focused enough on the naturalistic and frequent fluctuations in symptoms in BPD. And I'm concerned that we don't know which kinds of symptoms improve as people get better. So when I started thinking about what kinds of tools we would need to really measure BPD in clinical trials, in lab experiments, I started thinking about some of the features that I thought would matter. And those features, I think, include some simple things like efficiency, simplicity, portability. We can use it in the lab, we can use it in the MRI machine, maybe we can use it in the community. But I also started thinking that we should care more than maybe we have about validity and reliability, the psychometrics of our measures. And we should think about ecologic validity. How much does this really evoke the kinds of problems that people get into with this disorder? And in particular, are the tasks interactive? So I started with something simple, thinking about what turns out to be quite a large literature on reading face emotions in BPD. On my last count, there are 83 papers in this area, and the data are just all over the place. And I started wondering, why are these data, like I respect a lot of these researchers, why are these data so mixed? And there are a few things we sort of think are maybe the case, like neutral faces in face morph paradigms are read as negative. Probably stimulus presentation time matters, that we see more reliable findings when we look at the early attentional phase, if a stimulus is presented for 150 milliseconds versus if we look at the longer phase of untimed presentation, which has been done in many of the studies. There's some interesting things, like maybe negative bias in reading faces is read by people who are more, is driven by people who are more paranoid. So there's a few things, but out of these 83 papers, I mean, I was unable to come to a solid conclusion. And so I took a step back, and one of the things that I noticed was this issue about the face set psychometrics. And I honed in on looking at a recently published, carefully put together face set with my lab. And this is the Radiate face set. So this came out of the Yale Department of Psychology. It was built to have racial diversity and gender diversity, men and women, and several different ethnicities. And we were, so we ran a big prolific study, and we looked at just accuracy after we morphed these faces from neutral face for that person to 100%, which is what was provided in the data set. And so we have 5 levels of intensity for each face, and we showed them to like 80 people on prolific for each face. And this is what we saw. These are the individual trajectories of, let's see if I can use this, intensity on the x-axis. So as intensity increases, you would expect to see what you see on average, which is that people get better at correctly choosing the emotion for this face as the full intensity of the emotion emerges. But the variance between face stimuli, I mean, fills up almost the full space of the graph. So we decided to see if we could improve them. And what we did was we focused in on addressing the ceiling and floor effects. So you can see here in this example that this series of face morphs yielded an early ceiling effect. And so we represented a new set of morphs going from 20 to 60%. And then when we reran them, the curve looked much better. And then this one also had an early ceiling. We also saw some that had consistent floors at the low end. And we went through each face with visual inspection and chose new anchors and remorphed them. And we were able to markedly improve the performance and consistency of the faces. And so now we had a face set that we thought was much better. And we wondered if we would be able to see anything interesting in our patients looking at these. And so we ran another study, and this, yes, hello. Yes.
In the previous slide, are all the individual lines different faces or different individuals scoring those faces?
These are different faces.
Okay.
Yeah, these are different faces. So the consistency across faces is much better after rescaling.
Okay.
So then after we did consistency across, in this data set, we can't run traditional internal consistency across people because we used a large number of raters, and not all the raters saw all the same faces. So this implies that there's better consistency across raters, but we have not in this data set been able to run that like an alpha or something like that. Yeah.
So this is a rater scaling with what you assume is a broadly distributed typical population.
Well, I don't know that I assume prolific is broadly distributed typical. I would say you know, to be a prolific rater, you have to be someone who is willing to spend time for very low pay, a lot of time for very low pay, doing fairly fairly boring things generally. And so my read of those participants is consistent with other people's read, which is that on prolific as opposed to Amazon mTORC, effort is a little higher and performance is a little more consistent, but that the psychopathology burden is high. We think something like 30 to 40% of this sample would have a BPD trait level that rises to the level of diagnosable, and something similar for PTSD.
And I'm wondering if you just did machine learning analysis of spatial frequency, et cetera, on the same sets, would you be able to stratify or separate them in a way that would give you the same ratings or correlation?
Could I use the question is, could I use AI to try to figure out to decode the facial motions?
Yeah, to
I
decode
imagine
the
so.
states.
We haven't
To
tried
see,
it.
you know,
Yeah.
basically a truly, you know, objective validation where it's just pulling out patterns and not actually subjective.
Yeah, I mean, I think it's an interesting question. How could we train something to perform in the way people perform, right?
Right.
Because I'm not sure that I guess I'm not sure about the claim that people are objective, right? So if we're really interested in how people are going to respond, then to build a sort of humanized AI that has the same kinds of biases and things would be a really interesting. Yeah, it's an interesting question. Yeah, and potentially could be quite useful for pipelines. I think I agree that there's a utility here in improving our path to making more and more consistent face sets. But yeah, we want some variability, right? Because we do want to be able to pull out individual differences. So this is a challenge here. So we did try then formally looking at some groups that we're really interested in, and those groups are these healthy controls, people who meet criteria for current BPD on our assessment. This is a nationwide sample of people who we interviewed on Zoom. And then people who meet criteria for having had BPD in the past, but don't meet criteria now, but don't rise to the level of social occupational recovery, and then people who do. And in this sample, performance was really very consistent across the 4 groups, more than I expected. It looks like there's a difference for remitted on sadness, but it does not rise to the level of statistical significance. Of interest, we did replicate the finding about neutral faces that had been seen in the literature. When we zoom in on the neutral pane here, we can see that the current BPD group is statistically separated from healthy controls and from the remitted recovered groups, which it's a subtle difference, but they've been restored in the direction of healthy controls. So that's kind of cool, because many of the differences that we've seen are ones that hold all of the current or past BPD separate from the healthy controls and don't suggest markers that could be targeted for treatment. Furthermore, when we look dimensionally across our whole sample, we see that social dysfunction interacts with face emotion intensity such that at higher levels of face emotion intensity, more social dysfunction actually correlates with more correctness, but not at lower levels of face emotion intensity, which is consistent with our finding about reading neutral faces in BPD. And you can see that when we look emotion by emotion, that with neutral faces, there's a higher probability of correctness only at low levels of social dysfunction. So with more social dysfunction, reading neutral faces gets harder. And with more social dysfunction, reading angry faces, interestingly, gets easier, which may be adaptive, right? To catch someone a little sooner. Yes?
Is this function impacted by, I guess they're called processing time, time allowed to dwell on the subject? Would that change that relationship?
I suspect it would. In this study, we did not constrain the time, and in future studies, we definitely will. This is, yes, so this is something I suggested earlier that I think is really interesting, and we designed this experiment before we saw that result. And so I regret that these are untimed. So we do see variability in reaction time, and reaction times are longer in the more difficult, like lower intensity conditions, you know, when you have to dwell on it. But
I'm just kind of wondering if the ability to interrogate and process these emotions and faces amongst BPDs, or there's something about that, they're just better at it to begin with versus focusing on it more. You know what I mean? I mean, you can just be in a given amount of time.
yes, so if we,
better at it.
yes, and I think especially like this finding is going to be interesting to interrogate in that way. I think that's right. Yes.
Is there a context effect go on the one back? In other words, if you see neutral after angry, or if you see neutral after happy, do you actually diminish or enhance in different populations?
That's a great question. We have not looked at that in these data, but now that you've asked me, I will. We have some data from the large German BPD group. Katja Berch has published on primes before face presentations. And my understanding of those data is that trauma history, but not BPD, is impacted by the prime. So you would think that, for example, a negative prime before a neutral face would impact on your reading of the neutral face. And in BPD, there's not a differential effect of BPD there versus healthy control. Yeah.
I was wondering about the effect of that kind of perceiving the negative faces as more neutral. Sorry, the neutral faces as more negative. That's the opposite way. Affecting the previous data that you had showed us, or that kind of inconsistency in the literature, because that data set you showed us, I mean, you showed us the ceiling ones, but presumably there's ones that go in the other direction. People receive more neutral for longer. And you kind of then, like, as they're morphine, right? And then you kind of exquisitely controlled them. But if people do that, and faces that they presumed showed an emotion were neutral faces,
Yes.
does the data follow that direction? Or
I think I'm following what you're saying. Can you restate the question again, just to make sure I'm understanding?
Because when you started that there is this lot of variability in whether that would be perceived.
Yes.
And then when you really well controlled for how those changes in morphs happen, you only see the effect on the neutral faces. But if that changes in morphs were not as well controlled and faces were perceived as neutral for longer, you would assume in people with BPD, those faces would be presumed as negative, right, for longer across the board.
So these are not dynamic morphs. We're showing one photograph at a time.
Oh yeah, I'm sorry, I'm more thinking about, so then the kind of more photos in that set would be perceived as negative.
That's right,
so then
that's right, yeah.
Introduce this, that people with BPD would have more negative. But it's not based on the emotion, it's based on perceiving the neutral faces.
Yes, that's one of my concerns, is that we might not be distinguishing real differences, because these biases combined with the inconsistency of the faces lead us to false conclusions about what the problem is. Yes, I think you're right. Is that?
Yes, that was.
Yes, I think that's right. Yes. So to sort of summarize this part, I think we've said this, like, there are many areas of preserved function in BPD, at least on our best guess. And that makes sense. A lot of people with BPD are getting by pretty well a lot of the time. And however, there are some subtle differences in behavior that do seem to relate to clinical improvement. And I think we have some things to do next to think more about the neutral faces. I also want to talk a little bit about interactivity. And this is one of the areas where Reid Montague's group and mine interact. And some of my work was really sparked by work from Reid's group and from Brooks Casas, who published this lovely paper in Science in 2018 showing that in an economic exchange game, when things start to go south, the healthy thing to do is to try to offer too much to your partner to kind of reel them back into playing with you. And in this game, that's called coaxing. Oh, you walked in right in time, Reid. So I was just showing your old data. People with BPD were found to do that only half as often. And not only that, but increasing offers from a social partner were found to quiet what was thought to be an unfairness signal in insula in control, but not in BPD participants. And I thought this was really fascinating. And even more so when a follow-up paper came out with a reanalysis showing that in a parameterized computational model where the lowest level of theory of mind was thinking that you or thinking that someone else is irritable, people with BPD were far more likely to completely miss their partner's irritability and far more likely to not adjust when their partner was irritable. And I think this is really an important difference from the way many clinical models have thought about BPD, which is somehow people seeking out social problems. Here, there's evidence that people are missing negative social cues and missing opportunities to make repairs. And so if we know that these social decisions are impaired in BPD and that interpersonal instability is really a core issue, we might want to hone in on these really relationship relevant experiences that have to do with betrayals and experiences of shame and these other social emotions that can be so painful. And we want to use tools that are more precise. And so a lot of people have done this by using confederates, a pretend social partner. But when you do this, you have to invoke a deception. You have to try to convince your very vulnerable, in our case, participant, that this person is there to work with them, and that doesn't feel quite right. Also, it's a little harder to standardize. And also, importantly, a confederate is a stranger. That's not where people with BPD are having trouble. They're having trouble in close relationships, more like. So we started turning to standardized narratives that have been used in a range of settings to evoke specific states in addiction and trauma. And we like the idea of using these standardized narratives because we can tell people right what's going on, right? We're going to pull up the social situation. Nobody's going to be telling you anything that isn't true, but this is what's coming. And this has been done in BPD before, but not really to study social emotions. So we honed in on collecting stories about social betrayal. We asked a bunch of people with BPD about social betrayals they had experienced. And you might be worried about what this is like for people, but oh man, are people relieved to get it off their chest. They felt great telling us these stories. And we made sure that the stories included facts, details, and physiologic sensations. We used the method that Rajita Sinha has published for doing script-driven imagery, and we standardized them into 1-minute stories. And so this is an example of a story that we used, and you can see here in green the physiologic sensations, and we standardized the number. Yes?
Say that you had them include facts and kind of fact checked it. How did you do that?
So we just made sure that there was enough detail. So some stories don't work because they're too vague, or someone glosses over it, or you can't quite, we know this clinically, or sometimes with a friend, you're listening to a story and you think, wait, what happened? Like what? Yeah. So we just spent time, we let them tell an unstructured story. We listened. And then when they were done talking, we said, okay, so let me get this straight. What happened first? What happened second? Where were you? What was the season? What did your body feel like? Here's a list of sensations. Which ones did you experience? And we just really were able to nail down and standardize the narrative so that they all have standard numbers of adjectives, standard numbers of physiologic sensations, standard numbers of perceptions, things like you hear the door, you see your friend, right? This story's pretty bad. I don't know who read through it all the way, but it's about you think you have a best friend, but then your ex is coming to take their stuff out of your apartment after this terrible breakup, and your friend comes with them to take away the stuff, and it's awful, right? So then we say to people, have you experienced something like this? New participants hear this story, and we say, think of a time in your own life when you felt something like this. And then we ask them to hold on to that thought of that person who it happened with. And then we go forward, and we wanted to use this strategy to test an idea that really early life unpredictability in BPD instantiates expectations for volatility that lead to a failure to update learning rates when volatility occurs, because if that's what you're expecting, you don't need to change your mind when it happens. This leads to failures to change behavior. When you're in a conflict with someone, you're trying to let them know you're upset and they're not doing anything, you get more upset, you have a fight, and then your prior expectation that people are going to fight with you is reinforced, and you continue around this cycle. And so we wanted to try to use these stories to test whether social decision-making is impaired under stress, and to test how much these social decision-making problems are associated with clinical severity. So we ran an experiment where we compared the standard Confederate condition. You meet another person, they seem pleasant, you're told you're going to play this game with them, you play the game, to a condition where you hear this betrayal script, you think about a time in your own life, and you imagine playing with the person from your own life where it happened on that day. So this autobiographical recall is invoked. And then we had people play a social reinforcement learning game, and we checked how they were feeling after. And then in the Confederate condition, we let them know in the end that it had been a Confederate. The outcome measure here is this social evaluation task, and this is how it works. It's 290 trials. It has on each trial a social or a non-social choice, which is, do you want green or do you want blue? This is a one-armed bandit, so really green and blue are linked. Really, it's just, do you want green or not? A social advice from either the Confederate, or you imagine that your person from your time is giving you advice, and magnitude, how many points there are in the choices. You get a feedback after each trial about whether you were right or not, and there's a monetary reward for good performance, $20 at the end of the game. So pretty good reward. The task is built to have periods of high and low volatility on the reward schedule. And we focused, to start with, just on some simple outcomes. Did participants take the advice on the very first trial of the game? On what fraction of the trials did they take the advice overall? And what was their learning rate for the stable versus unstable phases? This is learning rates calculated using a simple Rescorla-Wagner model. We enrolled 20 people per group, and they were from all over the country. This was all done by Zoom. And what we saw here is that in the Confederate condition, there was a tiny increase in negative affect after meeting the Confederate, which reduced to baseline after the task. But in the script condition, there was a large increase in negative affect. But interestingly, these lines, I mean, I didn't make this up, but these lines are perfectly parallel in the two groups, right? So we would have thought that people with BPD would be made more upset by this story than healthy controls, but we didn't see that, and everyone returned quickly to baseline. So we think that the script is evocative, and it's not dangerous. People go right back to baseline by the end of the experiment session. When we looked at advice taking on the first trial, we saw something similar. Advice taking on the first trial, a proxy for initial trust, was much lower in the script condition than after meeting the Confederate. And taking advice overall was also much lower in the script condition than after meeting the Confederate. And there's like a hint of an interaction there. I'll say it's on the edge of statistical significance. This is probably not worth too much focus. But so we saw similar decreases in trust behavior in the task after hearing the betrayal script. So then we wanted to really ask, is there a difference as people get better from BPD in behavior here? So we enrolled a new cohort of people. These are the same people who looked at the faces. We met them in psychiatric interviews over Zoom. We asked them what recovery looks like, and this is what they drew. And then on one day, we had them play the game after hearing a neutral story. You go to the grocery store with a friend, you buy some milk, and or the betrayal story. And order was counterbalanced. Gameplay was at least a week apart, not more than 2 weeks apart. And in these data, we saw something interesting, which is that when we look at advice taking on the first trial, all three groups are separated from healthy control. So here we find evidence that as opposed to the face finding where we saw something that separates current BPD from people who've gotten better in healthy controls, here we see a phenotype that doesn't seem to change with getting better. So this is curious. We do see that in terms of learning rates that BPD and healthy controls both increase. This graph's a little complicated, so I'll kind of just walk through it. So we do see that the betrayal script evokes a higher learning rate, as you would expect. This is a slightly more volatile experience of hearing the betrayal story even in the stable phase of the task. So you can see that here and here. we can also see that task phase matters. So in the volatile phase of the task, everyone learns faster. Maybe there's a small degree to which BPD learned even faster between the stable and volatile phase in the Confederate condition. And we see a hint of that here, but you can see that it doesn't separate much. What we do see is, so there's a statistical trend of for the extent to which these slopes are different in the two groups. So I was left thinking that these findings didn't have a lot of bang to them. It's surprising that we didn't see big differences between BPD and healthy control in the slope of the change in negative affect or in the task behavior. And so I started thinking about why this might be the case. And I think the thing is that we've built a stimulus with intensity way, way out here. And what I really think is that that's not where the money is. I suspect that healthy controls in blue and BPD in green are both going to respond. I mean, everybody responds when they're hit with a really strong stimulus. I saw some of your faces looking at that story. It's not a little bit intense, right? But what if we had stories that were more medium intensity? And so I was thinking again about my face data and the morphs. And I thought, oh, maybe we could morph stories. And so we've tried a little bit in this direction to make story morphs. And so this is a story about walking down the street on a nice day. And what you can see here is that at the end, there's this sentence, which we can make less or more intense in terms of rejection. And we tried a little pilot of running these different versions on Prolific, and we saw that people can correctly identify which category the story fits into in terms of how negatively versus positively balanced it is. And of interest, in our Prolific sample, this measure of BPD dimensionality correlated, and you can see these are very preliminary small data sets, but correlated with judgment that the intent that the interaction was negative, anti-correlated with the judgment that the interaction was positive, and of interest, anti-correlated with confidence about that judgment. So the next steps here are to develop a larger story set. And this is one of the things we're trying to think about here. How can we make big sets of psychometrically validated story morphs? And how can we think about testing if they relate to behavioral response, if they relate to affective subjective response, and if they relate and how they relate to physiologic response? We're thinking about targeting pupillometry for our first pass, and then to try to use these to track treatment. Yes, please jump in. Yeah.
Sorry. So what you said just really struck me about negatively correlating with confidence. The higher the UPL, the lower the confidence. Is it completely incorrect to also think of a neutral phase as a phase that you don't have confidence in its potential expression?
That's right. Yeah.
And so is that kind of reflecting the same,
and does
where that uncertainty is actually the negative aspect of it, right?
I think it's a core issue. Yeah, I think that's a core issue. And I think that we have data from other settings to think that uncertainty is the problem in BPD. And one of the things that we've thought about, and it's really hard to figure out how to do this, but to try in the stories to disambiguate uncertainty from ambiguity from valence. And I think that if we can figure out how to do that well, it's gonna be high yield. I hope. I mean, yes, I think so. Yeah.
So slightly related back to the earlier question about time, if you tried different, instead of showing the story to read, if you did a video or you had somebody read it while they're listening, when you can just read it yourself, you can dwell more time on it.
They hear it. Yes, they hear it. Yes, and they're all.
They're reading it.
Oh yes, I'm sorry, I didn't make that clear. It's 1 minute, and they hear it. Yes, and then they're immediately asked to think of someone in their own life, and they type in the name. So we use a REDCap survey that we pair with the listening. So they listen, and then they type in the name of the person, and then between tasks, so they do the reinforcement learning task, and then we remind them of the person and ask them to think about them and tell us a little more about the situation, and then they do the faces. So it may be that some of the weakness in our face data is the diluted effect as well, because a little bit of time has passed.
Is there any other measure you could do that's a little less self-report, like even a wearable heart rate or something like that, where you just even when they're hearing the story, you look at that and then you try to see whether or not it stratifies across diagnostic categories and or predictive value.
Please join the study section reviewing this grant. Yeah, no, exactly. Yes, that's what we're planning. Yes, yes.
Okay, I mean, because it
Yes.
just gives you another number at least to actually
Yes,
include it.
yes, and it may be the case that there are more subtle signals that could be used even as, one thing that's a really big area of interest to me is like, if we could develop early alert sensors for these kinds of relational ruptures. And as part of this work is, in my mind, an effort to get toward provocations that can help us figure out what kinds of domains those sensors should focus. It would be really nice. If you're a person with BPD very early in treatment, you may have so little insight that you really don't see it coming. And this is what our patients say. They say, somebody just got mad. People keep getting mad at me, right? And if we could help people get a little like, oh, you're getting into like a yellow zone, you need to kind of like dump out of this situation. I think that could be helpful for people who are a little more alexithymic, a little earlier in the insight path, those kinds of things. Yeah. I'm mindful of time. I wanted to, maybe I'll skip this summary slide. I'm at the end of the talk. I wanted to thank the members of my team, especially Thea McAfee, who did the face work. She spent many hours morphing. Tatiana Allen, who I'm very excited is going to be going to work with Peter Fonagy doing psychoanalysis, PhD next year, and Berenice Torres, who's now in a PsyD program. She had the idea of the little drawings of recovery, and the recovery project is hers. And thanks again so much to everyone for having me, and to Reed for inviting me. I'm really grateful to be here. Happy to take any other questions.
Can you switch to your conclusion slide? I just
Here, wait, let me
read
use
it.
the microphone. I have a hard time hearing.
Can you switch to a conclusion slide? I just want to read through it.
Oh,
Thank
yes,
you.
of course, yeah. Yes.
Just what I'm taking away from this. I'm sorry.
Okay. I just want to make sure that I'm taking away the right things from your talk. So what I'm understanding is that you kind of think of BPD as abnormal reinforcement towards social cues that needs to be disrupted, like that reinforcement learning of there is a social cue. Previous experience has disrupted that reading of the social cue, which changed a person's reaction to it. And that has like this cycle that reinforces itself. And it's really hard to disrupt that, but it is possible, because the figure that struck me the most was that you have that one group of people who were in remission, but they still had the initial responsiveness. So there's something that they can override in their reaction, even though that their feelings or the underlying association still exists.
I would say a few things. I think that it feels to me as though, at least in some domains, the jury is still out about whether BPD is a disorder of over-responsiveness or a disorder of under-responsiveness. And it may be that there are ways in which it's both. I think that we should be thinking more about reinforcement schedules so cue and reinforcement volatility than cues on their own. And I think that, what was the last thing? I've lost my train of thought.
That in the people who are considered to be in remission, they seem to still have a very similar underlying initial responsiveness.
Yes, some things are probably harder to change than others. But it also may be the case, and I guess my concern is that we may have provided such a strong cue that we're not pulling out the subtle differences. And going about life, all of us do experience days with very strong provocations, but people with BPD are getting in trouble in the context of provocations that do not that would not necessarily cause so much trouble for someone else. Yeah, there's a question in the back. Yeah, here and then Kelsey. Yeah.
I was wondering, it seems like a lot of people, sorry.
Yeah. A lot of people that I interact with who have a diagnosis of BPD seem to go through this pattern of like getting a depression diagnosis, then anxiety, bipolar, and then BPD, which is obviously delaying the correct treatment that's going to help them. I was wondering if you have any insight on what's difficult to distinguish.
Do you think it's so? I would problematize the idea that the problem is people don't know.
Yeah.
I think the problem is people don't know what to do, and it feels really bad. And people have stigmatized ideas about BPD, so it feels like saying, so what I wanted to tell you is you're a jerk, right? And nobody wants that interaction to happen. So I think we need to do some work to destigmatize it, but also to offer people who are working in clinics the sense that they could be really good at this and helpful. And so what I would recommend is that there's a really nice treatment that doesn't require becoming an expert, where you can be really helpful to people, and it's called good psychiatric management. It pulls from the Winnicott idea of being good enough, right? And so you can be good enough at BPD and be really helpful and not harmful to people. So I would say check out GPM and share the gospel. But then the other thing is send families for support to the National Education Alliance for BPD, to the Family Connections program, because if someone goes home to their family and things are the way they always were, maladaptive efforts to help from families can be just as bad as maladaptive efforts to solve emotions through impulsive, dangerous action. And it can reinforce the cycle. So I don't know if that helps, but I'm very interested in that question. Happy to talk more offline. Yeah.
I actually had a very similar question, unfortunately.
No, that's good. I can talk
My
about it some more.
question was kind of specific to, though, the differential diagnosis between BPD, PTSD, and then in the ICD, PTSD, or complex PTSD. So do you see understanding these social symptoms, this variation, as giving us a better tool for differential diagnosis, or is that important to ask at all?
Yeah, so you and I talked about this a little bit yesterday. I mean, my read of the little bit of reinforcement learning literature here is, I think, at the leading edge of understanding this from my view, which is that, PTSD seems to be a disorder of probability detection, and BPD is a disorder of volatility detection. I think maybe. I also think that focus on BPD in the social domain is helpful to us as we're thinking about the difference between, for example, the re-experiencing and the avoidance and the high negative affect and sort of, fear-driven behaviors, choosing to stand here when I'm talking so that, this is PTSD. BPD is this rejection sensitivity, interpersonal instability. And it's not that there isn't lability in PTSD, but the lability is driven from those more fear cues. Now, there are people who've had interpersonal traumas, many of them in PTSD, and then we see some of these more mixed symptoms. People don't fit the textbook sometimes, yeah. But I think that doing your best to ask yourself, what's the best explanation for this, shortens the path to effective treatment. We talk a lot about duration of untreated psychosis in the schizophrenia literature. We should talk about duration of undiagnosed BPD, because treatment does really help. And also, it makes you feel less crazy and less bad about yourself. And that should be our goal. So I think that as we're doing better at trying to find mechanism and trying to find shorter paths to effective treatment, treatment should not be something, in my view, that takes years. I mean, I think it's an enactment on our parts that we can treat depression and schizophrenia and anything else on our list with good treatments in a month or two. And BPD, our plan is that somebody's going to be in DBT for 12 months, 8 hours a week. That's how is that? Yeah.
Bit of an anecdotal question, but also scientific. So I recently had a bad fever. And when you were going over the symptoms of BPD, I was like, that's exactly how I feel
Oh, nice.
as
Okay,
I'm getting
thank you.
over a fever. typically I'm relatively emotionally stable, I think, but
Yeah, you don't have to make the caveat. It's okay. Yeah, yeah.
but
Yeah.
yeah, I was just curious if there's any work looking at things like circulating chemokines or other immune signaling pathways. in
There
BPD.
isn't enough work yet, but there are a number of autoimmune conditions that are overrepresented in BPD. A lot of people have POTS, but also a lot of people have even these cartilaginous disorders. I've met 5 patients, I think, who have something I have never seen in any other setting, which is, Ehlers-Danlos syndrome. People have Ehlers-Danlos syndrome and BPD. People have, fibromyalgia, which I think increasingly we have reason to think is an immunologic dysfunction. So this is a question I share with you. It's very interesting. And I think also, it crosses with, to go back to the gene by environment situation, we should think about the experience of vulnerability that you have when you have a fever. We're returned to a state where we wish someone more comforting than us was there to do something about it, right? And so we're returned to a state of sort of psychological regression would be the psychological way of thinking about it. So I think both, and this is work that we should get into.
Okay, I'm gonna call it there, but thanks again for coming. It was a great talk.